Okay, so I'd like to welcome you to our current virtual public lecture for the Centre for Developmental Disorders at Durham University. So thank you all for joining us this evening or this afternoon, depending on where you are in the world. It's great. I know we've got a number of people from the US and lots of attendees from the UK and from all over the globe. So it's fantastic that so many people have been able to join us this evening, or whatever time of day it is where you are. So just to briefly welcome you to today's event. I'm Professor Debbie Ryby, and with Dr. Mary Hanley, we're directors of the Centre for Developmental Disorders at Durham University. And this is one of our public virtual lectures in our public lecture series. And we're today really pleased to have Professor Helen Dodd with us to give today's lecture. One of the very few benefits of a global pandemic is that we are able to hold these events using virtual methods, which means that we're able to bring together a really diverse and broad audience of people from lots of different disciplines, backgrounds, interests in the topic area today, and from all over the globe. So thank you all for joining us, and it's great that so many people are interested in hearing Professor Helen Dodd speaking today. If you have any questions that you'd like to pose to Helen at the end of her presentation, please feel free to use the Q&A tab. So you'll be able to type questions in there, and Mary and I will chair a question and answer session after Helen has given her presentation. We will be recording the talk today, and we will upload this onto the Durham University YouTube channel, and we'll put more information on the Centre for Developmental Disorders website when that is available, and a link there from the website. We hope to get that uploaded in the next couple of weeks. So thank you all for your talk today, and we'll move on to introducing today's speaker. Professor Helen Dodd is a professor of child psychology at Reading University, soon to be moving to Exeter University in the UK. And she's a real world expert on anxiety research. And today is going to be speaking about why some children become anxious, using insights from a range of different studies and longitudinal research in developmental psychology. Helen, as I said, is a professor of developmental psychology, of child psychology, and she's got lots of expertise in anxiety from all different areas of research. For example, looking at the mechanisms underlying anxiety, considering interventions for anxiety, and considering anxiety in a range of different neurodevelopmental conditions. And she'll be talking about just some of that research with us this evening. Helen is the holder of one of the very prestigious UKRI Future Leader Fellowships, and has also secured funding from a very wide variety of funders since completing her PhD only just over a decade ago, which is absolutely fantastic achievements in such a short and condensed period of time. So she's had funding from, among others, the ESRC, British Academy, Horizon 2020, and of course is the current holder of one of the UKRI Future Leader Fellowships. So also highly relevant that this year Helen is the award winner of the Margaret Donaldson Prize from the British Psychological Society's Developmental Psychology section, and later this year will give a keynote award talk as well as part of the BPS conference. So it gives me very great pleasure to be able to hand over to Helen now, who's going to be telling us about her research. And I'll come back to you with the Q&A session at the end of her talk.
Thank you, Debbie, for that lovely introduction, and also for examining my PhD thesis many years ago. Right, I will just share my slides and get started. And so I found it a bit tricky to work out what to talk about today, because I've been working on anxiety in children and thinking about why some children become anxious for about 15 years now. And the answers are complicated. There's lots of different reasons that children become anxious. So as Debbie mentioned, I've done research on children with developmental disorders. I've done quite a lot of longitudinal research, which is where we work with the same children as they get older, and look at who becomes anxious and whether we can predict from when they were younger who's at risk for anxiety. I've done some intervention research, and I'm currently doing a program of work around children's play in the context of anxiety. So there's no way that I could talk about all of that in the space of about 40 minutes or so that I've got now. So what I'm going to focus on is starting off by just thinking about what is anxiety, how do we recognize anxiety, different types of anxiety, and for those of you who aren't so familiar with anxiety as a kind of concept, and then talk about child factors and family factors that we've looked at in our longitudinal research, which show which children are at risk of becoming anxious. Then I'm going to talk a little bit about intervention and finish off by talking about play, because I can't help myself. So super happy to be here, really privileged to be invited, and also looking forward to answering some questions in the Q&A session a little bit later on. So what do we mean when we say anxiety? So there are other words that we use when we talk about anxiety. We talk about being worried, we talk about fear, we talk about stress, and of course feeling anxious. And there's lots of different ways that manifests itself. So for some people it makes us kind of want to curl up in a ball and hide from the world. For other people it makes us want to scream. Some people want to scream in some situations and want to hide in others. For some people it makes us feel sad, it makes us feel like we're missing out. For some it makes us worry, maybe affects how we sleep, for example, because we're worried about things that are going on. So normally when I give this kind of talk in person, I say to the audience, put your hand up if you've ever felt anxious. I could do that now, but we would all be sat at home with our hands up and not knowing whether anyone else has got their hands up. But I can promise you that when I do that, basically everybody puts their hands up, because anxiety is a normal emotion. So all of us feel anxious sometimes, and in many situations actually feeling a bit anxious is beneficial. So before an exam, before a test, before something important happening, that anxiety can actually spur us on a little bit to get us to focus, to get us to forget about other things, to prioritize what it is that we need to be working on. But then other times anxiety becomes a problem. And when we think about children, there's also anxiety, which is what we call developmentally appropriate or developmentally normal. So it's very normal for children to have a period of separation anxiety, for example, where they don't want to leave their parent. It's also quite normal for children to have fears that come and go. So they might go through a period of feeling scared of the dark, being scared of monsters, etc. But what is normal is that these things come, they hang around a little while, and then they pass. And children kind of move through these phases. And they're not hugely problematic. So typically a child might be scared of the dark, but you put a nightlight in the room and that's fine. And so they're not necessarily having a huge impact on their lives. So we shouldn't be worried about feeling anxious. Okay, the aim is not to create a world where no one feels anxiety. Anxiety is a normal emotion. It's there for a reason. But what we maybe do want to think about is how do we stop a proportion of children and adults getting to the point where the anxiety is really interfering with their day-to-day life? And how do we know when it is? How do we know when it's crossed that line from, do you know what, I feel a bit anxious about this specific thing, to this is actually really problematic anxiety for me? So one of the things we think about is whether the fear is out of proportion to the level of threat. We think about whether the fear exists in the absence of any actual threat. So when we feel scared of something where there is really no objective threat, then we might need to be thinking about, okay, well, why are you thinking that? Why are you feeling that fear of this thing that isn't actually, threatening you in any way? And the other thing we look at is how easily somebody settles back after they felt anxious. So if something happens, or they're exposed to something like a spider, for example, once the spider's gone, are they okay again? Or does the anxiety take a long time to go away afterwards? So, anxiety might be excessive when you see these particular signs. And really importantly, when we're thinking about whether anxiety is a problem, is whether it prevents a child or an adult from enjoying their normal life experiences. So is it having an impact at school? Is it impacting their friendships? Is it impacting family life? So if you could click your fingers and anxiety was taken away for that child, would their life look different? Would it look substantially different? And if the answer is no, then anxiety is probably not a huge problem and not something you need to be overly worried about. If the answer is, my goodness, it would be life-changing for them, then probably you're talking about a more significant difficulty with anxiety, and maybe something that you might want to think about getting some support for. So there are lots of different types of anxiety. So the feeling of that kind of, my heart's racing, my hands are sweating, I'm worried, I feel stressed, I feel aroused, I can't sleep, is anxiety. And that's similar across all anxiety disorders or types of anxiety. But the thing that causes it differs depending on the type of anxiety. So I already mentioned separation anxiety. So that anxiety occurs when a child has to separate, typically from a caregiver. It can happen with siblings, for example, and then they feel lots of anxiety about not being with that caregiver. Social anxiety happens when people feel heightened anxiety in social situations specifically. So that might be something like giving a speech, or giving a presentation, for example, or it might be things like going to a party, talking to people they don't know, that kind of thing. Specific phobias are fears of very specific things. So something like a fear of spiders, fear of the dark, fear of heights. And so there's a lot of fear and anxiety about this very specific thing, but it doesn't generalize to other things. And then in contrast to that is generalized anxiety, which is where people worry quite generally about lots of different things that are going on, rather than being focused on this specific thing as I'm fearful of this specific thing. So these are the most common types of anxiety. And it's also really, really common, particularly in children, for children to have multiple types of anxiety. So a child with separation anxiety might also have some social anxiety, for example. It's not the case that these are kind of totally independent and children have one and not the other. That does happen sometimes, but it's also very common for them to exist together. So just briefly, I thought this is helpful to think about those different types of anxiety and look at the differences in the age of onset. So separation anxiety and specific phobia are often the earliest in terms of their age of onset. So the average is around 6.5 years. So you can see that these are really starting quite early in life. They affect between sort of 2 and 7% of children and are more common in girls than in boys. Social phobia, or anxiety in social situations, doesn't tend to emerge until a bit later in childhood. So the average age there is around 9.5 years, and then sort of moving into adolescence. Again, more common in girls than in boys. Generalized anxiety, again, is slightly later, around 8.5 years in terms of the average age of onset. But what's really striking is that all of these ages of onset are really young. Okay, so if we think about mental health, we often talk about adult mental health, that, you know, I know somebody who's got depression, or I know someone who's got, you know, generalized anxiety or has panic disorder or something. But what's very common is that those adults who are having difficulties with their mental health will have been having difficulties with their mental health for quite a long time. And actually, we see this emergence of early mental health problems really quite early in children's lives. And so if our goal is to decrease mental health problems broadly, then we have to be thinking about children, and we have to be thinking developmentally about how do we prevent the development of these disorders in the first place. So a question that I get asked quite a lot when I talk about anxiety in particular, or children's mental health, is children's mental health getting worse? And the answer seems to be, very generally looking at the evidence, that yes, it is getting worse. There are reasons that the prevalence rates might be going up, which aren't to do with it getting worse, like we're more likely to look out for it now, we're better at diagnosing it, but that doesn't seem to be the whole picture. So there's a survey that happens, or a more detailed kind of diagnostic assessment that happens across England at regular intervals. And the difference in the emotional disorders for 5 to 15-year-olds between 2004 and 2017 was a 49% increase in those with emotional disorders, which is really striking. So 13 years difference, and we see this 49% increase in the proportion of children who have a mental health problem, emotional disorder. And of those emotional disorders that we're seeing increasing in children, the most common emotional disorder is an anxiety disorder. Okay, so anxiety, often people, when I talk about anxiety, are like, well, anxiety is normal, we don't really need to worry too much about anxiety, do we? But actually, anxiety is the most common mental health problems affecting children. And importantly, we know that anxiety often is a kind of gateway. If children are not given the support and treatment that they need when they're young, it can be a gateway to longer term mental health problems and negative outcomes in terms of their education, achievement, and also puts them at risk of things like substance abuse as well. So anxiety actually is really crucial. It's the most common emotional disorder in children, and it's linked to subsequent mental health problems. The good news is we can treat it fairly well as well. So, it's not all doom and gloom, but if we ignore anxiety in children, then we put children at risk for longer term mental health problems. And we know from research that I've done, I'm going to talk about in more detail now, but also lots and lots of research groups around the world have shown that these pathways to anxiety really do begin early in life. So we can identify children from quite young who are at risk. That doesn't mean that they necessarily will go on to have an anxiety problem, but that they're at risk for it. They're more likely to have a problem with anxiety than other children are. So as I sort of briefly mentioned in the beginning, it's really quite a complex picture. So I teach at Reading University a module about what causes anxiety disorders, and that's something like 20 hours or so of teaching. So I've got 40 minutes now to try and explain what I cover in that 20 hours of teaching, which obviously I can't do. So we're going to be oversimplifying things a little bit, and there will be lots of risk factors that we're not going to cover. But what I wanted us to kind of think about is this idea that a child carries with them this kind of cumulative risk. So any child, we can't measure it, of course, because we don't have all the information we need to do so, but every child carries with them some level of risk for how likely it is, how at risk they are of getting an anxiety disorder when they're older. And there are various things that feed into that risk. So one of the things is protective influences. So what are the good things that are protecting this child and stopping them from getting an anxiety disorder? So protective influences bring down this cumulative risk. So protective influences are good things in a child's life, like, having a good relationship with a best friend, having secure attachment with their parents, that kind of thing. And then there's predisposing influences, which are the risk factors, the things that increase their risk. So they might be things like genetics, they might be things like parent mental health. So every child, almost kind of from the moment they're born, has some protective influences and some predisposing influences which come together to affect their risk. So what's important about this is that even if a child has some of the negative risk factors, they can be balanced with protective influences as well. So it's not a kind of, well, you've got this thing, therefore you're going to go on to have this lifetime of mental health problems. It's just, that's not how it works. It's a really positive story, actually, that we can protect and bring down that risk in the face of these predisposing influences. And then, of course, there's just things that happen, so sort of life event things, and they interact with this cumulative risk. So if a child is at risk and then they get exposed to something like they're in a car accident, or something specific happens to them, they get bullied at school, then some children, if they've got really low risk, will cope well with that thing. If they've already got quite high risk and then they're exposed to that thing, then they're more likely to get anxiety. So there's lots of things working together, the child's background and developmental experiences, the family environment, and then the things that just happen to the child during their life that work together to affect how likely it is that a child will become anxious. And when we think about what some of those things might be, there's lots and lots of influences, of course. So there's things like genetics, the parent's anxiety, the child's temperament, life events that happen, we already talked about. There's a whole area of research about thinking styles, the way that children process the world, the things they pay attention to, the way they interpret things, and then learning experiences. So what is it that they see? What is it they observe? What is it that they're told? And lots of other things that are coming together to affect a child's risk for anxiety. So I'm going to speak about a few of these things, particularly the ones that I've worked on in terms of the longitudinal research that I've been doing over the past decade or so. So the first one I want to talk about is temperament. What we mean by temperament is just the way that the child is. So in adults, we might talk about personality, that, you know, my personality is this way and your personality is that way, and we're slightly different to one another. And that's just the way we are. They're the people that we are. And in young children, we talk about this as temperament. Those of you who are parents will be able to identify that, you know, from very early in life, even babies differ from one another. They have different temperaments. So some are smiley, relaxed, happy, quite easy to look after, and others are not, and are more difficult to look after. And then often those things change as they get a little bit older. So we can observe these differences in temperament from infancy, and to some extent they are inherited from parents. They are genetically based, but only to some extent. But temperament is relatively stable over time. So it does shift, and it can shift over long periods of time, but it's relatively stable. So if you have a child who is a particular way, it's more likely that they will stay that way than it is for another child who's not that way at all to become that way, if that makes sense. So you can predict what a child will be like based on the way they are right now. And so there's a particular temperament style which was first described in 1987 by Jerome Kagan, called behavioural inhibition. And these are actually the words that he wrote when he first kind of wrote about these children. And what he said was, among young children, some become quiet, cease the activity in which they're engaged, retreat to a familiar person, or withdraw from the field in which the unfamiliar event occurred. Other children of similar intellectual ability and social backgrounds, it's not about that, show no obvious change in their ongoing behaviour and may even approach the unfamiliar event. So we refer to this initial group who are quiet, they stop what they're doing, they retreat to their parent as an inhibited child, or behaviourally inhibited child. And the others who aren't really bothered and might even approach this new or unfamiliar thing as an uninhibited child. So I've done some work back in Australia with a group of around, we had 202 children who we first saw when they were 3, and they're now 19, which blows my mind. And we assessed them, and they were chosen as being either behaviourally inhibited or behaviourally uninhibited. So by looking at how they responded in different situations. So I'd like now to try to show you a video. So these are quite old videos because, you know, these children are 19 and they were 3 at this point. What's going to happen is you will see a child just playing in a room. The sound isn't great, but I will describe afterwards what it is that you've seen and what happens. But I'd just like to show you these 2 videos so that you can compare these 2 children. Okay, so we've left the child in the room. This is her mum sat on the chair, and there's just some toys, and we say you can play with anything you like. On the table, there's some quite normal toys, like a puzzle and some teddies. And then there's this black box, which we say nothing about. And you can see here that she's exploring the black box a little bit.
You can have it, but you can play with it right now. Your hands now, sweetie. You can play with it.
So someone has just entered the room dressed in a boiler suit and an elephant mask. She didn't know that they were coming. She says, "Who are you? Are you an elephant?" And then she asks, "What's your name?" So we'll stop that one there. Okay, and now if we watch this one for comparison, exactly the same. So the child has been left in the room with their mother, and there's toys on the table, and then this black box, and then the person's going to come in wearing the same costume. So you can see here that he's quite relaxed and is playing, but at no point does he explore the box. He just plays with the toys that are more familiar to him on the table. then the person comes in the room and he immediately goes to his mum. Okay, so I'm going to stop there because of time. But what happens is that the person in the elephant suit tries to get the child to play with her. And at no point will he engage, even when the mum says, go on, you're okay, you can play. He stays there next to his mum. And if you look at where his hands are, you can see he's also holding on to his mum. So he's gone over to her physically, but is also kind of holding on to her. And if you compare that to the first child, who carried on basically what she was doing and then had a little chat with the person who come in the room and asked what their name is, hopefully that gives you an idea of this difference between children and how they react to things that are novel, unfamiliar, that they're not sure about. So a behaviorally inhibited child responds like this little boy and retreats from that situation, goes straight to somebody who makes them feel safe. And an uninhibited child isn't too bothered about it and might even approach, as we saw in the earlier description. So we categorize these children as inhibited or uninhibited when they were 3. These are their rates of anxiety disorders when they were age 4 and age 9. So you can see here, the ones in the bars in blue are the proportion of children who are behaviorally inhibited who had an anxiety disorder. And they are much more likely to have an anxiety disorder than those who were uninhibited. And that continues over time, very high rates of anxiety disorders in those children. So alongside behavioural inhibition, we also looked at some other factors that I'll talk about now. So one of those was the mother's anxiety. So we did interviews with the mums and found out about their sort of lifetime history of anxiety. And what we found was that the mum's anxiety when the child was 4 predicted also that child anxiety diagnosis when the child was 6, when the child was 9, and again when the child was 12. So we know that this temperament style that the child has is in itself predictive of anxiety. So it's acting as one of those risk factor influences that's kind of having a negative effect on their risk. But in addition to that, the mum being anxious also puts the child at risk for anxiety over time. So why might that be? So what is it about growing up with a mother who is anxious or has a history of anxiety that might be affecting children's risk? So there's a few things going on here. So one is that parents communicate messages of threat and safety all the time. Children look to us to tell them what's safe and what's not. And we know that when parents are anxious, they're more likely to use this kind of anxious messaging and saying things like, oh, be careful, don't go too high, that kind of thing. And they're more likely, anxious mums are more likely to use catastrophizing in their communication, like, don't go too high, you might fall off and smash your head open, rather than, you know, oh, maybe don't go too high, you might start to feel a bit dizzy or something. And they're less likely to describe positive emotions, so to say, or does it feel exciting being that high, and that kind of thing. And also, so some of it's about what we say as parents, and some of it is about what children observe us do. So children watch and they model what their parents do. So there is some research around this. I'll just very briefly tell you about 2 examples. So this study, which was done by a PhD student of mine, Janine Uy, we looked at families of preschool children and their mothers, and we asked the mums how they would end some stories to their child. So we gave them the start of the story and said, how would you finish a story? And we coded then whether the parent ended the story in a sort of negative way or in a non-negative way. And we also asked the children themselves to tell the same stories, but separately to their mums. And what we found was that when mums said that they would finish the stories in a threatening way, the child was more likely to finish those same stories in a threatening way. So there's some evidence that, you know, the way that we talk to children and tell children stories gets kind of internalized by children, and that's the way they start to see that things might happen in the world. So that's evidence in terms of the sort of communication and the way that we talk to children. And then in terms of what children observe, this is a really nice study. It's quite old now, but from Lynn Murray, who used to be at the University of Reading, who worked with mothers who had social phobia and mothers without social phobia. And those mothers interacted with a stranger in full view of their child. And the mother was asked to introduce the stranger to the child, and then the stranger would approach and interact with the baby. And what they found was that mothers with social phobia displayed more anxiety during that interaction with the stranger and when their child was interacting with a stranger, and were less engaged with the stranger and less encouraging of the child's interaction with the stranger. So the infant is observing the mother interacting with the stranger and displaying this anxiety. And then what they found 4 months later when they saw the same children was that the children who were behaviourally inhibited and had the mothers who'd been avoidant and had mothers who were socially phobic were more avoidant of the stranger 4 months later. So the child had kind of observed what was going on there, and then 4 months later they were more likely to be avoidant of the stranger when their mother had expressed this anxiety. So it really demonstrates, I think, how much young children are like sponges, right? They're observing everything that's going on around them. So when they see other people behaving in an anxious way, some of that they learn, oh, this maybe is how I should behave in that situation. And it's very sensible, right? If we want children to learn, not to jump off the edge of a cliff because that's dangerous, then we model that. We say, oh, be careful because we're at the edge of a cliff and this is how we're going to behave. So we want children to learn from watching us. But sometimes what they watch and observe and learn isn't necessarily what we want them to be learning. So that's kind of thinking about parental anxiety. We've also looked within the same study, the same group of 200 children who we've been seeing for a long time, at parenting style. So early on, 2 parenting styles were identified that were potentially linked to anxiety. One being what we call overly controlling or over-involved parenting, which is when parents kind of jump in to help their child without giving their child sort of space to resolve things by themselves. So they might kind of help out, or like, I'm going to do this for you, or it can be quite controlling. So I don't think you should do it that way, you should do it this way, and not giving the child the space to kind of make those decisions and have that autonomy themselves. And the other is more sort of negative or critical parenting. So this negative parenting actually hasn't been very strongly linked with anxiety, across the literature or in our research. But this overly kind of controlling or involved parenting style does seem to be a bit more relevant for children's anxiety. So just to tell you briefly about some of the research that's been done in this area. And so one study is kind of quite a classic experiment now, is this, that parents are given a tangram puzzle, a bit like this picture here. And they're given 5 minutes to solve as many of the tangram puzzles as they can. And the mothers are given the answers to those puzzles and told they can only help their child if they feel like their child really needs the help. And then they're left alone for 5 minutes. The child has to try and solve the puzzles. And of course, what we're observing is the extent to which the mum helps the child without the child necessarily asking for it. And what they found in this study was that the mothers of clinically anxious children were more involved than the mothers of children who were not anxious. So they were more likely to kind of jump in and say, actually, here, put that one there, and I'll let them see the answers. And then similarly, a study by Dodd and Rapay, they found that what they did was kind of took mothers and children who were healthy, so no anxiety in the children, and said to the mums, can you be either really controlling in the next 5 minutes whilst your child prepares for a speech, or can you be really not controlling at all, totally let them do whatever they want for the next 5 minutes whilst they prepare a speech? And then they watched the child give the speech and observe the child's anxiety. And what they found was that when mums were more controlling in those situations, because they've been told to be, the child showed more anxiety. So this is really kind of confirming this link between the parent being sort of overly controlling or overly involved in what the child is doing and children's anxiety. Quite a little bit of a complicated figure, and I apologise for that, but what you can see here is across the bottom we've got age 4, age 6, age 9 and age 12. So these are points at which we assessed anxiety in this group of 200 children who we were working with. And across up the left side is their anxiety. So if you look at the kind of pinky orangey line up at the top, that should basically compare that to the green line. So the green and the orange, you can see start very close together, quite high up. So those are both lines belonging to inhibited children. So they're behaviorally inhibited, so their anxiety levels are quite high. But what happens over time is that the green line, those are the children whose parents were low in their involvement when we did the Tangram task. And what happens with those children is that anxiety declines beautifully over time. And by the end, their anxiety is in pretty much exactly the same place as the two groups of the uninhibited children. But those with the orange line, those are the children whose mothers were overly involved when we first assessed them when they were age 3 or 4. And what you see there is that those children, their anxiety remains high for quite a lot longer. And then it does start to drop off as they go into adolescence, but they're still quite a lot higher than the other groups. So what we see is that behaviorally inhibited children are at risk of anxiety over time only if their mothers are also overly involved. If their mothers are not overly involved, then actually they can recover quite well and their anxiety drops off over time. They kind of grow out of it, which we might talk about. But the other children are not growing out of it. So that over-involvement from the parent is kind of maintaining the child's anxiety over time. Hopefully that makes sense. You may have noticed that I've talked a lot about mothers. As a mother, I'm very conscious of doing this, and mothers get the blame for an awful lot of things. And often in homes, there's more than one parent present. There's very little research on fathers compared to mothers, but there is some research about a construct called challenging parenting, which is about pushing children out of their comfort zone. And there's a theoretical idea that actually fathers' role, in particular in thinking about children's anxiety, is to support children to leave their comfort zone by challenging them, by sort of teasing them, by splashing them when they go swimming, by rough and tumble play, that kind of thing. It's not my theory, that I'm just telling you that there is a theory of that. And there is some evidence here, particularly from this study, where they examined this sort of challenging parenting in mums and dads when children were 2 and 4, and they measured social anxiety. And what they found was that for the 4-year-olds, if the father was more challenging, then there was less social anxiety. Sorry, the fathers were more challenging when the children were 2, there was less social anxiety at follow-up. If the mothers were more challenging, there was more social anxiety at follow-up. So this does suggest that there might be some differences in terms of roles between mothers and fathers, and that this sort of idea of challenging parenting might be important as well. And it's also just to say that, you know, it's definitely not the case that mothers are the only ones to blame, but the difficulty is that fathers are very, very difficult to recruit into research. So we often end up doing research with mothers simply because the fathers don't come, or, you know, in that group of 200 children, we did do some work with fathers, but it was maybe about, you know, 40-50% of fathers. So it can be really challenging to get good research where you're looking at both mums and dads. But it's definitely not the case that this is only something that mums should be thinking about. Okay, so to move on to talk a little bit about prevention and intervention, I'm going to focus on one anxiety prevention program, which is called the Cool Little Kids program. I'm focusing on this because it's the most heavily researched prevention program for anxiety. And also because the research has been done by the team that I worked with when I worked in Australia on the longitudinal projects. It's the one that I'm most familiar with as well. So what they wanted to do in this project, or with this prevention program, was to support children who were at risk based on those risk factors that I talked about. So things like behavioural inhibition, and supporting parents who might be being a bit too overly involved or controlling with their child, thinking about supporting the parent anxiety, and getting children exposed to the situations that they naturally avoid. So if you have a behaviour inhibited child and they immediately recede to you whenever anything is novel or scary, you know, how do you get them to be exposed to those things? So this program was 6 weeks, groups of parents and groups of children, and trying to get them to really be thinking about these exposures, learning about temperament, learning some of the things that we've been talking about, thinking about the parents' anxiety and the parenting styles. So it's 6 sessions, so it's parent only, so we group treatment, the children are not involved. And these are young children, so preschool age children. So in the first study, they had around 75 children in both groups, so a treatment group and a waitlist group. All the children were behaviourally inhibited, so all at some level of risk for anxiety. So 6 parents in each group. So they ran this prevention program, and then they followed them up 1 year later to see, has this helped to prevent anxiety? What they found at that point was that the behavioural inhibition hadn't changed between the groups, which fits with this idea that temperament is quite stable over time. But there was a decrease in anxiety in the treatment group that was greater than the decrease in anxiety in the non-treatment group. So when they first saw them, 90% of these children already had an anxiety disorder. But a year later, those who'd done the treatment, 50% had an anxiety disorder. Those who did nothing, 63.5% had an anxiety disorder. So you see that some of these kids just naturally are growing out of it, but more got better in the treatment condition. And then they followed them up again 3 years later and found that those numbers had got bigger. So at that stage, those who'd had the treatment, 40% had benefited and no longer had an anxiety disorder. Sorry, 40% had an anxiety disorder, so 50% of them had at baseline and then didn't by follow-up, and versus 69% in the control group. So there is some argument there that when we do prevention work, actually we might need to wait quite a long time to really see those benefits of the intervention work. And actually in this study, they then followed them up once they got to adolescence, which is really unusual. And there was some evidence there that it didn't make a huge difference in terms of anxiety, but that intervention program might have helped to prevent depression. And depression often has its onset during adolescence and is much more common in girls. And so it was when they looked at adolescence, it was depression in girls, which had really gone down in those girls who, when they were age 3 or 4 years old, their parents had done this intervention. And it may be that we kind of need to invest in early prevention, even though we know it may take 10 years to really see that benefit. If we are preventing some children from a lifetime of anxiety and then adolescence and depression, then is that not a worthwhile thing to do? And we'll come back to that a little bit as well. So this program they've tried to roll out on a kind of bigger scale in Australia. So delivering it at a kind of population level rather than doing it as sort of 75 parents in a quite controlled way. And it hasn't been as successful. So they found no significant difference at 1 year follow-up between those in the treatment and control group, although there was a difference, but it wasn't statistically significant. And what's really interesting is that less than 30% of those taking part at this kind of population level prevention attended most of the sessions, and only about 20% said that they used the skills most of the time. And I've worked on a similar study and really found it difficult to get families engaged in doing it when their child is not yet anxious. So this is a real challenge, that if we know children are at risk and we want to work with families to prevent, how do we ensure that families have the time to do that when it doesn't feel like a priority to them right now? That makes sense. So just to finish up, I think I'm not going to talk about the play stuff because I'm going to run out of time. So I'll just finish up with this. There is some argument about whether early intervention is appropriate for child anxiety and whether we should be trying to prevent it. And I think this is a really interesting argument. And I think it's important that, we don't just give a one side of this argument. So I wanted to kind of share with you what the negatives are perhaps of doing this kind of prevention work. So one of the arguments is, well, wouldn't the money be better spent treating children who already have an anxiety disorder? Because when you do prevention, you're spending money treating children or doing this prevention program with children who may never become anxious. Lots of them just get it better by themselves. So we're kind of spending money supporting children's mental health who may be fine anyway. So would it be better to wait? It's possible that the approach might inadvertently send the message that children who are quiet and reflective are not valued and that we're trying to change them and make sure that everybody's an extrovert. I don't think that that's the case, but I think it's an interesting thing for us to consider and ethically ensure that that's not what we're doing, and we are preventing mental health problems, not trying to change children. And finally, another issue is that selecting children to take part in the programme, of course, requires us to say to parents, your child is at risk. And that may label the child and increase the parent's anxiety and worry, neither of which are things that are going to benefit the child. Having said that, you know, I'm a strong advocate for early intervention. And, you know, there's very good evidence that it's cost effective. And I believe the aim is not to change the child or change who they are, but it's to provide parents with the tools they need to help their child live a happy and healthy life. And it helps parents to distinguish between these valuable individual differences and those behaviours that actually are impacting the child's life and preventing the child from living this kind of fulfilling, happy childhood. And I think there's also a positive effect of increasing awareness and decreasing the stigma of mental health problems if we're working with families from a young age. And for me, childhood should be happy and carefree. And if we wait until children are clinically anxious and have a disorder and can get treatment for that, at that stage, the child has already missed out on a couple of years of feeling carefree and happy. So I think the earlier we can provide this support, the better, because it allows children and families that freedom and that carefreeness, and that's what childhood should look like. So I'm working at the moment with some colleagues at the University of Oxford on a new programme which is called MyCats, which is minimising young children's anxiety through schools. And so what we're trying to do, we've developed an online prevention programme for parents, and we're recruiting children via schools who we believe might be at risk for anxiety and getting their parents to take part online. So if anybody's listening who works in a school or who wants to know more about whether their school might be able to take part with this, you can email the email address there, or there's also the website there too. So I think I might stop there and skip through the play stuff because I've run out of time. Oh, I'm going to do practical tips and then I'll stop. So things to take away: try and take a step back, watch and wait, rather than jumping in and helping children too soon. Often they can solve problems and they can work things out for themselves, and we often as parents want to do it for them, but give them a bit of space, give them some autonomy to help them solve these things for themselves. Keep an eye on your own anxiety and the messages that might be sending. If you need help with your own anxiety, try and get that help. As a parent, if you're looking after your own mental health, then that is going to benefit your children. Try and gently support approach rather than supporting those avoidant behaviours. When children approach, when they have opportunity not to avoid, then they have an opportunity to learn that things aren't as scary as they think they might be. Try and step back to allow children to make decisions and experience that kind of everyday adventure that childhood should be full of. I didn't talk about this part, but being outdoors is really great for children, and being in nature as well. So providing as much outdoor time as possible is good for children's mental health, and looking out for opportunities to support contact with nature. I put together a few resources here from some fantastic organisations. I'll skip through them, but I think those will be available to you afterwards for anyone that's interested in following up. So thanks very much.